Hello everybody, welcome to the webinar of the Civil Society Wash Fund. Today we are holding a webinar on hygiene behaviour change. Could you please raise your hands in the box there if you can hear fine? Great, it looks like a few hands are popping up there, so that's good to hear. Thank you very much. Okay, so this webinar is being conducted by the Civil Society Water, Sanitation and Hygiene Fund, which is supported by the Australian Government's Department of Foreign Affairs and Trade. The Civil Society Wash Fund supports 29 projects in 19 countries, and the two NGOs that we will hear from today, two of our NGOs working within the fund, they are SNV, Bhutan, so from South Asia. We also have Water Aid in Papua New Guinea, so representing the Pacific. We also have projects in Southeast Asia and Southern Africa. This webinar is part of a phased learning approach leading up to the final fund learning and reflection event, which will be held in Brisbane in August, so less than a month away now. Just also to mention, the webinar is hosted by the Wash Fund Management Facility, which is managed by Palladium International in Brisbane. So I'm Bronwyn Powell, and sitting with me is Amy Zhuang from Palladium in Brisbane, Australia. So welcome to our Australian and international guests. First thing we'll do is to talk through some of the ways that the webinar platform works. I think the first thing is if you could please mute yourselves. By clicking the mute button. If we don't have that, you'll hear a bit of feedback. Hopefully you're not hearing any feedback right now. Also, it helps if you use a headset, so a USB headset. And if you wish to speak, please raise your hand by pressing that little hand thing, which a few of you have already become familiar with. Also, there's two ways to chat. As you would have seen, we already have the chat box. So these little boxes down the side can pop out and you can see what's in them. There is a question box and there is a chat box. So the chat box will go to everyone, so the whole audience can see it. The question box is something that only you can see, and then if it's responded to by one of the presenters, you'll be able to see the written response as well. If you have any technical difficulties throughout the course of the webinar, please use this email address, and there's also help on the GoToMeeting website should you need it, but hopefully we will encounter few technical difficulties, even though we're all spread right around the world. So this is what you will be seeing on your screen. Yeah, that's the question box there where you can type your question, and then the hand to what you need to do to raise your hand. Moving right along, I will go ahead and introduce the speakers today. So from the fund side, we have myself, I'm the Knowledge and Learning Manager, and Mark Ellery, who will be facilitating the question and answers at the end. The first presentation will be Gail Pigelow from Water Aid Papua New Guinea and Edith Kamundi from International Water Centre, speaking about formative research on infant faeces management for behaviour change in East Sepik communities, Papua New Guinea. Then we'll go on to adapting, testing and integrating behaviour change communications based on emotional drivers of nurture, disgust and social affiliation for hand washing practices, which is an integrated government program in Bhutan. That's with Dr. Adam Buran, who's joining us from the London School of Hygiene and Tropical Medicine, and Bala G. Gopalan from Upward Spiral Creative Agency. And then at the end there will be time for question and answer, so we can do that verbally then. So you get an idea of our faces. This is all of the presenters today. So Gail Pigelow, welcome Gail, is currently working as the WASH Program Officer at Water Aid Papua New Guinea, where she's focused on working with local partners. She's worked for 6 years in the WASH sector and is passionate about behaviour change and scaling up for hygiene behaviour improvements in Papua New Guinea. Edith Kamundi from International Water Centre, also based in Brisbane, calls herself a WASH enthusiast who for the last decade and a half has worked in sub-Saharan Africa. She's a sociologist and is focused on tackling public health problems. Dr. Adam Baran, hiding there behind a teacup, is a researcher at the London School of Hygiene and Tropical Medicine. He's worked previously on the Super Ama project in Papua New Guinea, which is a predecessor to the work that's being presented here today, and his research interests are in household environmental health. Balaji is a communications specialist interested in creating positive social change, and for the last 15 years has worked on a range of social issues: livelihood improvement, safe food, microfinance, fair trade, sustainability, governance, education, to name a few, and has worked most recently in the last 5 years in behaviour change communications with partners such as the Tata Trust, Unilever, and of course SNV. I won't introduce us too much, other to say that I'm the Knowledge and Learning Manager. Mark Ellery is our WASH facilitator, who will also be joining us at the Fund Learning event and has over 20 years experience in WASH governance, in particularly South Asia, and then Amy Zhuang, who has an accounting and international development background and has been supporting us in lots of ways at the fund management facility. So without further ado, I will hand over to our first presenters, so that involves us switching screens, so just bear with us while that happens. I'll move the presenter over to Edith, and Edith, hope your screen's ready to go with the presentation. And then Edith will be hearing from Edith, so take it away.
Muted.
Let me share my screen there. There we go. I hope everyone can see my screen. I need to move this. Okay. So we're going to be talking about our project in Papua New Guinea. We're working with WaterAid and our local partners is Integrated Rural Development Initiative, and our local research partner is Divine Word University, and we've been working together with the National Health Promotion Department of Papua New Guinea in support of getting this program. So we'll make the first presentation, then Gail will take over, and then I'll end the presentation. So for us when we started this project, we were looking to address what we considered the most risky behavior in the areas we were working in, which is in East Sepik province in Papua New Guinea. And there's already evidence showing that infant feces management not a lot is happening in that space, because many people consider baby poo to be harmless as compared to adult feces. So in many of the communities we are working in, already effort has been done to improve sanitation facilities and looking into safe disposal of adult feces, but very little attention has been done to infant feces yet. According to a situation analysis we did, these are also very harmful, and they also lead to causing of diarrhea diseases, especially to children under 5. So our approach to designing this behavior change intervention, we began with a situation analysis by looking at a range of behaviors and practices around safe disposal of feces and hand washing practices in communities in East Sepik province. And from this, we wanted to understand what are the communities doing, what are the attitudes. Then from there, we selected a behavior that is in safe infant feces management, and we defined it to include disposal of the feces and cleaning the feces of the baby plus hand washing. So we found that infant feces management is a little bit more than just how we dispose the baby poo. So we thought that the best way to be able to tackle it as a behavior change program, and from the results of the situation analysis, it was important to include also the behavior of the primary caregiver, who was mostly the mother. From that, we did our formative research, we did an analysis, we've designed a behavior change campaign. We shall talk about it a little while. We pre-tested our campaign tools together with our local partners, and then currently we are doing our piloting. So from the situation analysis, we were able to identify what is it that we considered our risky behavior. This risky behavior is what is causing most harm. So out of all the behaviors we looked at, including menstrual hygiene management, things related to hand washing with soap, we found that's the one thing nobody was paying attention to, that even in homes that people had improved hygiene, sanitation facilities, there was still a lot of open defecation practices and less care being done, and because it's not harmful, a lot of the mothers were actually handling the feces with their hands. So we thought that mothers should be our key target audience if we want to influence behavior in infant feces management. We looked at how do people dispose, are the feces being cleaned from the baby's bottoms, and hand washing with soap, and using these three, we formed our formative research questions. We conducted the research in 4 communities in PNG, and the communities were selected around the same communities that we were working in, with the rest the rest of the scope of the CS Wash Fund project, and also communities already that had some facilities going on in terms of water and hygiene, so that we could actually understand the barriers and motivators to improved facilities. Just to share just one component of the research findings, we found when we looked at in terms of disposal practices, we didn't find a lot of variations between the communities. So we found if you have, out of these 4 communities, 2 of them are near the beach, while others are much more inland. And that would be the little variation in terms of, you'll find that the ones that are inland are less likely to practice open defecation than the rest. But in terms of what are the different practices in different households, there's very little variation used, little variation in how the households were disposing of the feces. The other things we found that were very important for us in our formative research was that we found that practicing of openly disposing the feces was the most widely practiced of all, and we found that many of the mothers, sometimes they would not even take the feces away from the open spaces. Either even the burying was not so much practiced. So in all the 4 villages, the most commonly practiced was I don't want to say open defecation. It is more of about them being thrown in the open spaces around the houses, under the houses, next to the toilets, into the rubbish bits and all that. The other interesting thing we found was that the knowledge about improved hygiene practices was very strong. Most of the mothers, when you spoke to them, they knew the importance of good hygiene. They knew the importance of reduction of diarrhea diseases for their families. But this was not resulting into practices. The other thing we found was very strong is that infant feces, or dealing with infant feces, was viewed as a woman's role. Even some of the fathers that we spoke to said that even when I do practice or help my wife taking care of the baby, I don't want people to know about it, because it's not something that men are viewed to see. So we had to look at those findings and ask ourselves, how do we design a campaign that addressed all those things? A community that has increased knowledge, one that has widely practiced open disposal of feces, and also how do we balance that out in terms of promoting the women's role, that it is more of a community and collective effort in the household. In terms of the non-health motivators that we found that the 4 most important drivers for changing behaviors in infant feces, we found nurture. That innate nature for mothers to be good mothers was a strong driver to how well they handled their babies. Then there was issue of being pride, in terms of being seen as a good mother, of being seen as somebody who lives in a clean home. That was very important. In terms of cleanliness, this is the flip side to disgust, because baby poo is not seen as disgusting. So when we talk to the mother, nobody felt that they felt disgusted by touching feces of a baby, but they also felt that they needed to clean themselves after handling the baby. For example, when they remove the nappy from the baby, they'd go put the nappy in water and then wash their hands. Maybe not with soap, but some sort of wiping would be done. So that need to be clean was very strong, but they never felt disgusted. So it's about balancing the difference. The other thing was environmental cues. This was because when you spoke to the mothers, they would say, yes, I wash my hands with soap if I see it, if it's next to me. If it's near where I am, I will use it. But most of the time, there was the aspect of, I can't remember this, I was too lazy, I was busy, and other competing priorities. So if there's a reminder like the physical presence of soap, that goes a long way. So our campaign has been designed using these 4 key motivators. The other thing we found that there was need to have a mix of communication channels, because most of the communities working, there's not much electricity, telecommunication is not very strong or non-existent, There's maybe radio once in a while. Obviously, there's no TV because there's no electricity, but there's a lot of community drama and community engagement. So we had to look at those type of what the best way of engaging the community. So we had to mix those communication channels, mixing of posters and maybe drama and all that. We shall have a look in a minute. So where am I? There I am. Okay. So from there, we designed a 4-week campaign. So Gail is going to take us through the 4 weeks campaign and tell us how it's happening. I'm not able to remove this. I'll just put it aside. Gail, you'll take us through the next few slides. Hello? Hello?
Yes.
Thank you, Gail.
So, yes. So looking at the activities and the changes of the campaign process, the first week is week 0, which is the preparation week, starting with baseline data collection. The enabling actors are briefed on the campaign and change agents are mobilized and trained. Week 1 is when the triggering is done. Here the community is briefed on the campaign. Enabling actors deliver a call to action and the community members pledge to support the campaign. So we should be able to see change agents and enabling actors mobilizing the community members, promoting the campaign messages, motivating the households to practice the 5 steps and monitoring infant feces management practices in the community. And community members are motivated and committed to supporting safe infant feces management practice in their community. Those are the changes. Week 2 is all about reinforcing the knowledge. So evidence showed that knowledge on good hygiene practices is high among mothers, with many expressing high awareness on spread of germs, the need for good household hygiene practices, and the importance for these practices. Though this knowledge has not resulted fully in improved practices for all households, it is important to reinforce the knowledge again on the risks associated with poor infant feces management practices. So the 5 steps are introduced by the change agent in small group discussions with the mothers, who participate and identify small doable actions that they can do to practice the 5 steps to safe infant feces management. Looking at week 3, during this week, the aim is to promote messages around motives for safe infant feces management to mothers and fathers. The motives identified in the formative research were nature, cleanliness, environmental cues, and competing priorities to reinforce existing knowledge on infant feces management risky practices and also to create awareness on the 5 steps for improved infant feces management behaviors. In between these 2 weeks, mothers should now be aware of the health risks of poor infant feces management and should be motivated by nature, cleanliness, and social norms to practice safe infant feces management. They are also performing small doable actions and are supported by fathers and community members, motivating other mothers to practice the 5 steps as well, and fathers are also motivating other fathers to support safe infant feces management. As a result, reduced environmental contamination and disease risk, leading to healthy families and healthy communities. So if we look at week 4 now, this stage, the community has actively participated in the activities. They have received messages through the small group discussions, and the posters placed at distinct places visible to all residents. It is important to end the campaign in the same celebratory tone. So activities include a meeting with community leaders, collection of stories of change, and conduct of community meetings. The expected outcome is that the campaign comes to a successful end with a pledge to adoption of improved infant feces management practices to the 5 steps. So week 4's aim is to sustaining the practice of safe infant feces management. Change agents share their monitoring results to the community, and enabling actors celebrate the community achievements, and community members pledge to continue to support each other in practicing the 5 steps, and implementation partners plan for final evaluation. So by this time, community members are committed to sustain the 5 steps in their community. all the same leading to the impacts, reduced environmental contamination and disease risk leading to healthy community. So the tools we're using are the posters. We also have a drama depicting the message around the 5 steps to safe infant feces management, and the call to action, which is a statement whereby the community leader signs as they pledge that their community will take on and support the behavior change campaign. And we also have the pledges where community members or each household in the community pledge to support the campaign. The early results of the piloting, we are currently on week 3 of piloting, and we're expecting more results to come by the end of this month. So we have seen, however, slight changes happening. Some mothers are motivating other mothers to practice safe infant feces management. For example, mothers are encouraging themselves to throw dirty water into the toilet after cleaning the napkins so that it gives a good impression of your household as looking clean as well as your children. All these motives of nature and cleanliness comes up again. So also our father, who is also a change agent, talks about how they are ignorant of the good behaviors and that they must make those good practices a habit and become a normal part of their lives instead of believing in superstitious beliefs about culture making children sick.
Thank you, Gail. So we've want to share about 3 key lessons that we've learned from this program in terms of interacting with the different stakeholders. The first one, we found that using the community-based change agents has been very effective because they're able to communicate the messages using the nuances that communities understand, more believable, having male champions for change, but also promoting that IFM removes that stereotype or the myths around the role of men being involved in managing and helping or cleaning their babies or disposing of feces. The role of government, we found out when we were designing the tools and we used a local artist and we went out into the community. We worked with the National Health Department in WeWork at the district level. And one of the things they told us is that they do a lot of health messaging in the communities, but they've never looked at infant feces because it's not seen actually as a hygiene promotion or a wash program, but it's things that are left, hopefully, that the nutrition teams will look into. But they have been very supportive in terms of in the design, in advisory level, and we are now exploring, WaterAid is exploring ways in which they can look into scaling up this project to other areas of PNG. Having a strong monitoring system, like we are saying, we're expecting results from the pilot at the end. This is one of the things we are designing to ensure it is integrated into the system. How do we put in strong systems where we can be able to have good data coming out and recording the lessons, even from how the community is moving from belief of cultural beliefs into adopting new and safe infant feces management practices. The second thing that we have found very useful is how do we integrate behavior change into existing social systems. So one of the things that we found when we were looking at is when the only way the mothers were getting information about how to take care of the babies was from the clinics. And that message was given to individual mothers. But there was no practice of the social norm of talking to each other because it was felt everybody will get to the clinic at their own time and get the information. So the way the 5-step campaign is designed, it is engaged to try and promote a community way of influencing each other. And already those kind of things are coming out in the pilot. The other thing we found, the issue of the role of men and women. When we collected our data, it showed the primary caregivers are the mothers. Therefore, we design our messages as mothers as the target group. So trying to balance out and ensure that as we are addressing an evidence-based campaign, how do we ensure that we are not promoting the same stereotypes that women or mothers are responsible for everything? So it has been a good balancing act. So using more men as male champions, as community-based agents, ensuring that we have activities meant for the men only, so that we can help them to move from just being influencers of decision to actual practitioners. So we are hoping to see whether that will bring out results. I think Gail has spoken a little bit about cultural beliefs. That's, I'll skip that, but that has been a very good lesson in terms of moving people from looking at things we found in the formative research about witchcraft and others when it came to disposal of feces. Finally, the other lesson that we have found is about scaling up. What next? So exploring ways onto what can we do with this campaign? So one of the things that we're looking is programs such as wash and nutrition, programs that exist in Papua New Guinea. How can the infant feces management campaign support that? Those are some of the avenues we are exploring. Other things we are looking at is how do we able to document, because we've seen that there's not a lot of work that has been done in infant feces management, and if there is, it's mostly about disposal, not so much about the behavior that surrounds the practice. So what can we do with it now? So we hope we'll be able, at the end of the pilot, we'll be able to have strong data to communicate to the rest of the sector on how infant feces management has worked in PNG and whether there's anything we can share. And other ways is explore ways of what else in PNG can we do that the IFM results or this IFM campaign can be used in existing programs or integrated into existing programs such as wash and nutrition. So from Gail and I, thank you very much, and we'll take questions at the end. Over to you, Bromwell.
Yeah. Thank you. Thank you very much, Edith and Gail. That was great. I will now ask Bala to take to lead on that presentation. So I'll move the presenter over.
I didn't hear you.
Unmuted. Muted. Unmuted.
Please go ahead,
Hi,
Bala.
this is, okay, hi, thanks.
Hi, thanks.
Muted.
So thanks Edith and Gail for a wonderful presentation on infant feces. As told before, like this is a presentation of a campaign called Suprama, which was originally done in India and proved to be quite successful. And how do we adapt and integrate it to an existing mainstream government program in Bhutan? That was the challenge before us, and it was part of the CS Wash Fund Impact and Innovation Grant. And the partners were PhD Bhutan, the Public Health and Education Department of Bhutan, and SNV Bhutan, London School of Hygiene and Tropical Medicine, and Upward Spiral, which is our own creative agency. Broadly, we'll look at the presentation in this flow. We can start with the background and then look at the process of designing the program and the actual design itself, and how it was piloted, what were the outcomes, and then the learnings. Moving on, Suprama campaign basically was trying to establish these two different modes of communication, which is like, looking at emotional motives to change behavior vis-a-vis using knowledge to change behavior. And traditionally, a lot of health communication, if you recall, will be in the area of giving people knowledge of germs or diseases or how to practice a certain behavior, etc., and assuming that could change behavior. And Suprama tried to look at a different way of promoting behavior change, which was on emotional motives. And the basis for that is from the evolutionary psychology work done by Robert Unger and Val Curtis of London School of Hygiene, where they actually propose a three-level brain model for the individual, like the first level of the brain being the automated level, where reactive kind of behaviors that we have, which are like instincts, like when you touch a fire, like let's pull out your hand and automatically, or automated behaviors like habits like toothbrushing or driving to an office, which we do without even having to think much. The second level of the brain is the motivated level of brain, which is like, for instance, when we feel hungry, we go out and look for food to fulfill ourselves. There are different kinds of motives that work behind our behavior. And the final level of brain that evolved was the brain of executive brain. It's a brain of knowledge, which helps us make different choices between, like having looked at different aspects of between different choices, we can make a specific choice. and it's a very rational kind of a brain. So when we look at a communication which is the rational knowledge based, we are essentially talking to the executive brain, which was the latest brain to evolve and therefore has very little influence on our behavior. Most of our behavior actually happens at the level of motivation or automated levels. And if you look on the right side, there is this pyramid of 15 fundamental motives that Val Curtis and Robert Anger have identified. And these kind of motives that help improve the state of our body, like hunger and comfort, and the state of the environment around us, like create or status, and then finally there are motives that help us, improve the state of our brain, like play and curiosity. And so you can actually refer to more of this work in this paper, behavior-centered design paper, in the links that I've given below. So Suprema campaign, so whenever we start a new campaign, we look at what motives can we therefore plug into for changing the behavior. In the Suprema campaign, we identified 3 different motives. The first one being nurture. Nurture in terms of, when you look at mothers, they're constantly telling children a whole lot of good manners, like talk respectfully to elders and don't lie, etc. And that normally includes a lot of cleanliness behaviors. Like comb your hair and have a bath and so on. So we saw that there was a great opportunity to include hand washing with soap as part of the good manners that a good mother would teach her children. And the second powerful motive was found in disgust. Disgust, evolutionarily speaking, is the motive that helps us avoid infections, like all the things that we are disgusted by, or things that have germs in them and that can infect us. And in the campaign, we use disgust as a motive powerfully. And the third one being affiliation, which is our need to belong to a group and be accepted by a group. And so this was also used in the campaign quite powerfully. So the campaign basically was like a 2-day campaign which involved films, it involved street theater, it involved a lot of community level activities, and these 2 days were separated by a light touch of 2-week follow-up, and fairly high intensive campaign in those 2 days. So the challenge before us was adapting this to a so actually, before that, you can actually refer to more of this campaign at suprama.org if you're interested. The challenge before us in Bhutan was to adapt this successful campaign to the constraints that we had in Bhutan, because the campaign was being rolled out through a mainstream government program to integrate this into a sanitation demand creation workshop that they had. So it was basically a 2-day workshop attended by about 20 to 40 participants. One person from each household was asked to attend this workshop. And within this 2-day workshop, we had probably a 2 to 3 hour window where we could introduce a hand washing with soap component to it. And this workshop was being conducted by health assistants, and mostly it used participatory kind of communication methods. And so this 3-hour window is what we had to adapt the entire campaign that we had in Suprema. So the process that we followed for developing this design, it started with formative research, which included staying over at people's home to observe what they do, and also group discussions with mothers and fathers, and also certain behavior trials where we ask people to keep soap and water for a certain period of time near the toilet, in the kitchen, etc., and see how they
Unmuted.
Hi Bala, we can't hear you anymore. Can you, I'm not sure if something's happened to your sound. We just we lost you when you started talking about the formative research. Offline. Oh, Adam, can we see if you can pick up from here? It looks like that something's happened with Bala's connection. Sorry about this, everyone. Do we have you, Adam? What are we going to do?
Yeah.
Great. I'll just try and bring up the presentation on my screen if you can keep talking, and I'll try and get the presentation to where Bala was up to. You there, Adam?
I'm here.
You're very faint.
Yeah, I don't know what the problem is with the...
We can hear you now. Apologies to our audience. I think there's been a internet connection dropped out. Adam, we did hear you for a second there. Can you keep trying to talk, see if we can get you back?
I'm going to talk now.
Yep. It's still very faint.
So Adam, I think the question is, can you either continue to, can you bring it up on your screen, or Bronwyn will try and bring it up on her screen. Can you take off over where Bala dropped out?
I will do my best. I can certainly take over the second half, and I'll do my best to get it through the remaining slides of Bala's.
Great, thank you.
Adam, hi, I'm back online,
Oh, you're
so
back.
I can see. Sorry. So I don't know where you guys lost me, but I was just talking about this ad in Ghana, and then I was beginning to speak about the glowworm demo. Glowworm demo, for those of you like who are not familiar with it, it's
Sorry,
basically a glue
Bala.
that...
I think we were back on the formative research slide, if you don't mind going back a fraction. We lost you a slide back, I think.
Okay, basically I was speaking about the process of how we arrived at this design. So we had an existing design which we needed to adapt.
Muted.
We started with formative research, which included direct observations, group discussions, and also certain behavior trials, which was about keeping soap and water for a few days, asking people to keep soap and water for a few days at the kitchen, at the toilet, etc., and seeing how they find the whole experience and learning from that. And at this stage, we finalized definitely the motives of nurture and disgust and affiliation being quite powerful in Bhutan as well for hand washing. And also we got a good understanding of the physical setting in which the whole behavior was being performed. And we followed this up with a creative development research where we tested key ideas on the motives that we had identified, and which could, and the reason for calling it creative development is to not look at an idea as getting an yes or no answer from a respondent, as much as to use the findings to develop the idea much further. And at the end of the creative development research, we had three different ideas. We narrowed down to one single idea. And then we developed a three-hour program which can fit into the workshop, and that was live tested with the potential targets like the father and the mother who will attend the workshop. And this live testing was also done at 2 levels, so as individual capsule as well as part of the existing government program. Moving on to the design, it's design of the program. So there were basically 3 big components to the program. The first one, it combined 2 of the existing activities for hand washing which have been done in different parts of the world. One is this ad that was released in Ghana which showed a mother coming out of the toilet. She has got something in her hand, you can see by color that's there in the hands, and when she touches the food, it gets passed on to the food and then to the child that she feeds. And so this was an ad that was released in Ghana and had a certain amount of success. And the other activity which has been quite popular for hand washing, which is a glowworm demo, where it's a glue that you put on your hand, and first you wash it with water, and then when you shine a UV torch, you can still see some spots on the hands, and the spots go away when you wash it with soap. So while glowworm demo has been quite popular, the thing that we were asking ourselves was, is there a way we can make it land as disgust rather than as knowledge of there is something on my hands? And that's when we decided to combine these 2 things. So the activity happens like people hold a sequence of cards of a mother going into the toilet, coming out, and then she's touching the food, and then she's feeding the child. And so we asked 2 people to come forward and do a role play of a mother and a child.
Unmuted.
Mother goes into the
Hi.
toilet and comes out, and then we put the glue of, sorry.
Sorry, Bala, we just had a request
Hello?
if you could talk a bit more slowly. We have some colleagues, I think, in Cambodia who are having trouble with the pace. If you could talk a bit more slowly, thank you.
Muted.
Yeah, sure, we'll do. We ask a mother and a child to come forward and do two people to come forward and do a role play of becoming a mother and a child. And so they do the whole sequence of going into the toilet and then coming out, and then when the mother comes out, we actually put the glue of the glow gel in her hands, and then we ask her to wash it with water as the mother does in the cards, and then feed the child who's doing the role play of the child. And then we ask everyone, like, is your hand clean? Everyone says it's clean, and but then we show the magic of showing your hands under the UV torch, and then you can see there are spots in your hands. Then we ask the audience, like, what should she do now? And then they themselves come back with the answer of soap, and then the process is then repeated to show that she's washed her hands with soap and there is nothing in her hands. And so this was one activity, and this was also a key adaptation from what we had done in Suprama. In the case of Suprama, we had a street theater which was in disguised, and there was a character called the Laddu Lingam who was a dirty character making very dirty laddus and feeding children. And so here it was, since the whole workshop had normal health assistants and not theater actors, so we had to adapt it to something that they could perform. So that was the first activity in the workshop. The second, so you can actually refer to the Ghana ad in the link below. The second activity was story. This is basically the story. It is a story of a father and a mother who bring up their child in a very with a lot of good manners, so that the child goes on to become successful. And the parallel is drawn between how the children are like seeds, and when you like nurture them properly with water and good attention and teaching them good things, then they can grow on to become like giant trees in their lives. And so this story is then shared with the participants, and then we have an interaction with the participant about, like, what do you think about it, like how do you think it's important to teach good manners, etc. And this is followed by a pledge to wash their hands with soap and the critical occasions. And the next activity is based on this insight that it's not good enough to just for people to be motivated to practice a new behavior, but often we can be very driven to practice a new behavior, but next morning we can get up and forget about the whole thing. So how do we get people to plan for the new behavior that they are going to practice? So here we designed an activity. It's called a settings game. Basically, there is a water and soap and mug kept at the middle of the participants, and all the participants hold different cards which have one specific activity that they do. The activity could be cooking, it could be watching television, it could be going to the shop, or going to the toilet, or washing the child's bottoms, or feeding the child, etc. And the player has to actually figure out when they should wash their hands with soap. The moderator would say, like, now you go to the shop, now you go to the toilet, now you go and feed the child. The player has to figure out when they should wash their hands with soap, and if they forget to do that, then they lose the game. And so this section of the game basically brings alive the need that fact that all of us can forget. When we are trying to practice a new behavior, we can forget, and that is often a blind spot. And the second blind spot is the fact that we may not have the physical setting in place. So in Bhutan, for instance, the tap is often shared by more than one household, or some people may not even have a tap at home. So therefore, where is the soap kept at the home itself is because it's being shared by everyone. That's a challenge. So then the second part of the game, we actually move the soap around, and that makes it all the more difficult for the player to play the game. And that brings up the importance of physical setting and practicing a new behavior. And this game is then followed by a planning for both these aspects. How do you remind yourself to practice a new behavior, and how do you create a setting at home to practice a new behavior? And we give them some tools like reminder stickers, a diary to keep track of their behavior. And also certain hand washing station cards are used to discuss what kind of setting they can have at home. So this workshop, following this workshop, we also do a household visit to check if people have actually set up a physical setting for practicing the new behavior, have they put up the reminder stickers, and also to kind of congratulate them for practicing the new behavior. So the three activities of the closed-down demo and the story and the settings here is part of the workshop itself, and the household visit is something that happens later. So you can refer to the campaign materials in the links below. I'll hand over now to Adam to take over for the rest of the presentation.
Okay, thanks, Bala.
Adam?
Can you hear me now? Can you hear me now? Can anybody hear me?
Yes,
Yep,
we can hear you, Bala.
We can hear you, Adam.
Right. Thanks, Bala. I'll push it on. So we evaluated this intervention in a cluster randomized controlled trial. So a small trial with 3 arms. One arm received the standard community development for health approach. One arm received the CDH plus, which was the intervention with the hand washing component, and one arm was the control arm, which received no intervention. We had 8 basic health units in each arm delivering the interventions, and we collected data from 15 households per BHU from 1 respondent per household. These respondents were adult female. In the CDH and CDH plus arm, they were respondents who had been exposed to the intervention. Next slide, please, Bala.
I think he's ready for the next slide, please, Bala. And could you try and speak up a little bit more, please, Adam? It's quite faint still. Thank you.
Sorry, I can't do much more about that. I'm practically shouting into the mic here. The outcome measures were self-reported hand washing with soap at key times, which these data we collected using a structured recall tool with pictures. So respondents would arrange a set of pictures to show what activities they had performed on the previous day, and the pictures included key occasions when we would hope that hands would be washed with soap, and they also included pictures for hand washing with and without soap. So the idea was that respondents could report on their hand washing practices without being aware that that's what they were reporting on, and therefore hopefully reducing respondent bias in the data. We know that self-report through questionnaire surveys, for example, tends to massively over-report hand washing and may well have led to a ceiling effect had we tried it. Our other 2 outcome measures were the presence of soap and water at the latrine, which we collected through spot check observations, and hand washing awareness and normative beliefs about hand washing practices in the community, which we collected through a questionnaire survey. Next slide, please, Bala. In terms of the reach and compliance that the intervention achieved, the 115 out of 630 households in that arm, so 82% reach, and 413 households, or 66%, received a follow-up visit. We found reminder stickers had been placed in 60% of kitchens and latrines. 93% of respondents had been given a copy of the story in a comic book format to take home, and 72% said they had shared this with children, and 64% with adults in the household. 76% of respondents had been given a record sheet to record hand washing activity at home, of which 50% had completed at least 1 day, and 33% had completed the entire 21 days of the record sheet. So in summary, we thought the intervention was achieving reasonably good reach, and there was reasonably good sign of compliance with the slide, please, Bala. So just explain what this table is. This is the table of the key outcome measures. The left-hand column is the outcome The next column is the results from the control arm, then the results from the CDH arm, and the final column is results from the CDH plus arm. The percentages are mean percentages across the 8 DHUs in each arm. And the stars denote where there is strong statistical support at either the 0.05 or 0.01 level. So if we look at the first row, this is hand washing with soap at all key occasions as measured by the self-report picture activity. We have 13% in the control arm compared to 17% in the CDH arm and 20% in the CDH plus arm with strong statistical support on hand washing at all occasions. The following 4 rows break down those hand washing occasions. So if we look at hand washing after fecal contact, which is after using the latrine or after cleaning a child, we see that both the CDH and the CDH plus arms have had a similar impact and both have statistical support for a change. However, looking at the next 3 rows in the table, the CDH plus arm is having an additional impact on the hand washing activities associated with food handling. So before feeding a child and before eating, both showing a strong change as compared to the control group. And before preparing food, we're showing a trend in the right direction, though the statistical support for this was low. Final row is looking at the availability of water at the latrine. So this was actually households who would place a bucket with soap and water somewhere close to their latrine. And here again, we found a strong effect in the CDH plus arm as compared to the controls. So the summary is that both CDH and CDH plus seem to be improving hand washing rates after toilet and after cleaning a child, but CDH plus is having an additional impact on those hand washing activities associated with food handling and eating. And in addition, the CDH plus arm, people are rather more likely to keep soap and water available in the vicinity of their latrines. Next slide, please, Bella. In terms of learnings, the self-report through the picture exercise seemed to work in that we were able to detect the difference between the different arms of the trial. However, we don't know what actual hand washing prevalence was. We haven't done observation of hand washing here, so we don't know for sure how the self-report relates to actual prevalences. In terms of impact, we saw a modest increase in hand washing at key times and a modest increase in soap and water provision. And this was achieved through a relatively modest investment in hand washing promotion. So as compared to Superama, there was reduced investment, a shorter period of contact time. Additionally, the CDH workshop had certain constraints around it in terms of who we were able to target. We could only target the attendees at the workshop who were not necessarily women from the key target group. To influence 2 behaviors at a time, so they were not devoted solely to hand washing, but they were primarily about sanitation promotion with hand washing as an add-on. And finally, the timing of the rollout may not have been ideal since it happened in the winter, which may have discouraged people from taking up the practice at that point in time. Next slide, please, Bella. In terms of design, what I think was most interesting about the intervention was this combination of the glow germ demo with the idea of the contamination pictures from the TV ad, which has been successful in Ghana. There are a number of things that could possibly be changed going forward if we wanted to make further investment to increase the strength of the intervention. And these would include using audiovisual format for delivering the story, higher emotional impact than we have managed through the flip chart alone. We could also look at adding some school-based activities to this and introducing some rewards and social norm-based activities similar to what we use in Superama. We could also possibly use the household visits more intensively to push for soap and water provision. It seems these are having some effect, but we could have extended the reach of those and perhaps repeated those visits to achieve more effect. In terms of scale up, it was currently implemented district-wide as part of the government program. We found there was high acceptance by implementers, and there is now an intention stated by the government to include the hand washing element as they roll the campaign out across other regions. Bala, I'll hand back to you for the final slide, I think.
Yeah, thanks, Adam. From the point of view of adapting an existing intervention into a new geography, some of the learnings are one, involving all stakeholders right from the beginning of the process, and also keeping them engaged at key stages in the process. So we had after every field visit, we would actually meet back with the stakeholders to brief them on what has happened and take their point of view. And that brought in a lot of ownership into the program, and that's why they probably want to scale it up at the moment. And second is to define constraints right up front in terms of what are the human and financial resources. So in this case, the constraint being the workshop that was conducted by the government. There could be other constraints in your geography. So it's better to define it up front so that then the design can be around that. And you may also want to restrict it to one behavior at a time rather than trying to influence two, which is always quite difficult. And building a program on emotional motives rather than knowledge, that again seems to have impact in the right direction. And we would also urge to follow a human-centered design process. Like even if there is an existing intervention, it still makes sense to go through a certain amount of formative research to understand the context and to test the ideas through a creative development process and live testing. And in the design that you may want to adapt, you may want to include address the design gaps such as like school or affiliation and rewards. And there was also great merit in investing in a proper learning program, because often there is a loss between design and delivery. So even in the case of the rollout in Bhutan, there was proper learning programs for the facilitators. And it makes sense to pilot in a smaller scale, evaluate it, and then learning from it to refine it before scaling up the program. I guess that's where we can end our presentation.
Thank you very much, Bala. I'll just put it back on the screen from here now, and then we'll take questions and Mark will lead on that.
Thank you, Bronwyn. While you're doing that, I'll just start explaining and just give a few words of overview. Firstly, I think we chose these two presentations because they present, if you like, two of the models that we are exploring in terms of hygiene behaviour change. The first being one where more investigating, if you like, the individual ingredients that are necessary for changing hygiene behaviour. But knowing what the ingredients are doesn't necessarily mean that you can affect all those ingredients, which is essentially what's been WaterAid and IWC presented for PNG, is formative research looking at the various components for hygiene behaviour change, and then investigating what do we do to influence them. The second one is quite a different model of saying, well, if people are motivated enough, if we can determine what are the drivers of change, then people themselves will assemble the ingredients in the necessary way to bring about that hygiene behaviour change. So one is looking more at the drivers, and the other is more looking at what are the components and how do we move with the components. One is the first example is a little bit more localized, looking at what are the local ingredients, and the other one is looking a little bit more, can we find things in common that enable us to, if you like, roll out a scalable model of behaviour change. So a little bit, that's why, just explaining the choice, if you like, of those two presentations. And so what I would like to do now is to open up for a few questions. I noticed already there was one on the line that Edith has already responded to, which was to lay out the actual steps in behaviour change. And let me pause here and ask, look for hands raised for people who would like to speak and raise a question, or who would, I see a hand raised with Sam Hussein. Would you like to raise a question?
Yeah, thank you. Yeah, do you hear me? Hello? 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 Hello?
Yeah, we can hear you, Sam.
Yeah, thank you giving for the opportunity. It's very nice presentation. Both of presentation was very good, and I learned many things from. But we are also working here for the fecal stress management. We have developed the BCC strategy here also with the formative research, and this is very similar with the both presentation. The first we had infant fishes management presentation. From that presentation, my question is, the fathers are agency, work at agent, local community agent, but most of the father work outside, isn't it? So how can the fathers give their time to act as an agency? So can you share your experience on these issues? Hello, do you hear me?
Yes, we can hear you.
Yeah.
You go ahead, Ed. Yeah.
Okay. Hussein, is that your question, or you wanted to say some more? You felt like you wanted to say some more.
No, it's that's it from my side. And then other question I have written, I have also for the second presentation, how the campaign in the Super Amma campaign, how the campaign will campaign effectiveness will the monitored, and what will be the substitute when the program will close, then how campaign or the activities will run. That is my question. That's it from my side. Thank you.
Okay, maybe Mark, do we answer or we wait for more questions? Or just go ahead.
Sorry, I was speaking and I was myself muted. Yes, two good questions. Thanks, Sam. One for Edith on the role of men in behaviour change for infant faeces management, and then one for Adam and Bala on sustainability. How is the campaign sustained after? Thanks, Edith.
All right. Okay. Just to answer your question about whether men are actually there, our experience was that out of the 4 communities we worked in, two of them the men are actually there working. They live within the community or they work in the town and come back. That is where we are conducting our pilot. And even when we went to the other 2 communities, we did find yes, a small percentage, not as compared to the many women that are in the community, but we felt that if we were able to talk to the men who are already there, then it would have a bigger impact, because there was little differences in the thinking from household to household. So it is not that big a challenge. They are not continuously absent for long periods of time. So that is one of the advantages in the communities that we worked in. But we did note in one of the communities that is close to a big palm oil industry that we couldn't get hold of the men at a certain date when we were conducting the formative research, so that they can come into the community. So it's about working our campaigns around the community calendar. That's what we have tried to do, so that we can get them to get as many people as possible. Yeah, I think that's all I can say. But the few that we have there, especially the ones who are community leaders, the ones who are working in the beetle nut farms, those have been very good in terms of being change agents and promoting the improved behaviors and influencing each other. Gail, I don't know whether you'd like to answer that also.
Yes, also in our communities, like men are always the influencers in the community, and women listen to them. Everyone listens to them. So it was easy. More of the change agents were, half of the change agents were also men, and they lived in the community. They live in the community all the time. They don't go out anyway. So
yeah. Thank you. Over to you, Mark.
Sorry for the delay. All right, Adam and Bala, a question again from Sam about the sustainability of the campaign after the project period.
Yeah, so I'll give my perspective on it. Maybe Adam can add as well. So, Sam, one way in which the behavior sustains is if it becomes a habit itself, and that's one of the things that we rely on in our program. So, this evaluation that Adam presented itself was done after 3 months, if I'm not mistaken. So, there is a certain sustenance of behavior that's happened even after 3 months, and that's because a habit has been formed of some kind. And even in the case of Superama, we had evaluated after 1 year and found most of the people had continued to follow the behavior. However, there is probably a need for a further engagement in campaigns to make sure more and more people come online. Like the next set of people, we probably have got the early adopters, but how do we get the next set of people to also start practicing it? And for that, we may need next phases of campaign. Adam?
Thanks. You go, Adam.
I wasn't clear whether the question was about sustainability of the behaviour or the sustainability of the intervention itself. Just repeating the point that the intervention, now that the pilot phase has been completed in one district, the plan was for the intervention to become part of the government programme that's being rolled out across a number of districts. So in that way, the implementation is going to be sustained beyond the study.
Great, thanks, Adam. That that addresses the issue of the scale, and I think Bala was talking more about the sustainability of their behaviours. So I think you've covered both there in terms of scale and sustainability. Thank you very much. I note there's a question from Peter Shari on the regarding seasonality. Pete, would you like to? It's a very good question regarding Bhutan.
Okay, you've got me now. Thank you. Hi, Mark. Thanks for the opportunity and thanks for the presentation, everyone. I was just wondering what the seasonal effect was about the implementation of the pilot in Bhutan. We did speculate whether it's because it was winter, so the water was cold, or people didn't want to spend much time in the latrine or washing their hands with cold water. That was the extent of it. Thank you.
Perfect. Thanks.
Yeah.
Thanks, Peter. And I think in climates where also your water freezes from time to time, the seasonality is a big issue and a big a really good question for the guys. Thanks, Bala.
Yeah, so this is more of a speculation and based on personal experience of trying to wash hands in Bhutan during winter. So this campaign happened during December and January when it is so even sub-zero temperatures in some places, and which means the water has to be heated specifically for if one is so keen to do that, and also the whole aspect of washing and touching water if it is cold is not very pleasant. So the assumption here would be that if when you're trying to practice a new behavior and of hand washing, and this could be a serious barrier, it may not be the best time to do a campaign like this. But it is a speculation, and it's not like we have not done necessarily a campaign in winter and summer to compare.
Thank you for that. As someone who works mostly in the tropics, it wasn't obvious at first. Thank you.
Thanks very much, Bala. Any other, I just did a quick scan. I didn't see any other hands raised. Anyone else have questions that they would like to raise? If not, I will. Yes, please, Bronwyn.
Sorry, Mark. I did notice that Jeff Revel's hand is up. I don't know if you had a question, Jeff, or if that's just from a previous.
Yeah, hi, I do. Thanks a lot for a great presentation, and thanks for sharing all that information. My questions from our group here is about the stickers mentioned in presentation number 2. It was exciting to see that 60% were visible. If I understood correctly, 60% were seen upon monitoring visits 3 months later. And I just wanted to know if Bala or Adam wanted to comment, because we usually see it difficult to, as a sector, to modify the household settings, the environment in the household, especially as compared to schools. And so we wanted to know, does this suggest like a lot more potential? Are there ways that they see this potentially, other things happening to support nudges in the household that we haven't done, that others haven't done very much of before? Thanks.
Adam, can you?
I'll have a go. Hi, Jeff. Can you hear me?
Yes, we can hear you, Adam.
Okay, great. So the stickers, I think we used similar in Superama. In Superama, we actually had these eye stickers, so to give the impression that you were being watched at home. So I think it suggests there is some potential for changing cues in the environment. And this is also done successfully in Nepal with Bhutan's study on food hygiene, where he included a lot of reminder stickers and changes to the household environment. So I think there is scope for this. I think in Bhutan we were probably helped by the fact that we had these rounds of follow-up visits from the health assistants, and knowing that you're going to be visited can be a prompt to change something in the home. So there's scope for it. I don't know whether the stickers that we had were powerful in their own right, but the fact that they were there means that there's some scope for experimenting with that as a way of prompting behavior change at home. I don't know if that's answering your question, Jeff.
Thanks, Adam. I think we'll have to, I realize we've run over time, and I will, if I could just finish with a quick advertisement, if you like. Firstly, finish with a round of thanks to everyone for participating. And then I'm going to finish with a quick plug, if you like, for this ongoing discussion on the CS Wash Fund. Bronwyn, can you set up to share my screen, please?
Yeah, it's happening. Yeah.
Thank you. What I would and I think I'm just going to reflect briefly on what's on the eDiscussion website, is, if you like, these two approaches to hygiene behaviour change, where we're exploring, if you like, this idea of looking at the components of hygiene behaviour change versus, or complemented, or in conjunction with the motivations for behaviour change, under the pretext that if you get the motivation right, the motivated will make the ingredients available and bring the necessary ingredients. To the third question that the CS Wash Fund has really been saying was, how do we measure it? And measuring hygiene behaviour change being an incredibly difficult and tricky challenge, where observed behaviour change versus reported versus knowledge are all fairly different things. And then how can we measure the hygiene behaviour change, but ideally, how do we go beyond that to actually measure the impact of that hygiene behaviour change, recognising, if you like, that hygiene behaviour change is in some ways the holy grail of WASH activities, because it's a very low cost intervention. It can be extremely effective, but extremely difficult to bring it about. So it's only low cost if we can affect the hygiene behaviour change that effectively enough to change health. But it's not, if it doesn't work, then its public health cost is quite high, because you're spending money and not actually seeing the change. So the monitoring and evaluation is, if you like, a key question of seeing, is it really working? And so, if you like, the e-discussion is seeking to pull together what we know and new ideas ideally about what we measure and how we measure, in order to work, whether it's on the determinants of behaviour or on the motivation for behaviour. So with that, I would like to just conclude with thanks to both Edith and Gail, Bala and Adam, and to all of you for attending, and encourage you to join the e-discussion and to post your experiences or to respond to some of the other people's experiences on that platform. Thank you very much, Bronwyn.
Great. Thank you, Mark. I think you've done all the thanks, but again, thanks to our audience for attending and our presenters. I hope that you got a lot out of that, and yes, please do continue the conversation on the e-discussion currently running on the website. Okay, have a great evening or morning, whatever time of day it is where you are. Thank you.